Welcome to this Court of Patrons webinar, this time with Peter Hutchinson, who's the Director of Clinical Research. Peter, or Hutch, everybody calls you Hutch, I will if I may. Research, as well as it is for surgeons, of course. How much has research had to grind to a halt during this lockdown? Everything followed since.
Well, for surgical research, which is a major part of the Royal College activity, it has been quite a tough time in terms of the general surgical research we've been doing, the activity of the fellows, their lab work, some of the translational research, and it's been quite tough for the clinical trials that we've trying to deliver. So although that's been difficult, the COVID situation has created some other opportunities for us in research. And sadly, we know this has been a major impact on the nation and patients, but in terms of the research activity, I think currently we're moving away from our traditional research and towards looking at some of the COVID issues.
Explain how, in what way is, for those who aren't familiar with this, how is COVID affecting surgery and how can surgery affect COVID?
Well, I mean, people think about COVID and the effect it has on patients generally medically in terms of the problem that we've seen with lungs and the medical side of things, but actually the impact on surgery has been enormous, both for the patients, their families and surgical services and the way we deliver them. That's partly due to the availability of facilities, and clearly we've had to give over intensive care units and operating theatre capacity has reduced. But beyond that, it's been very difficult to manage the patients with their surgical conditions in the context of the pandemic.
You've set up a special clinical research group looking at COVID, and what's specifically that looking at?
So around March, April, we recognised that there was a big unmet need in terms of research as it affected surgery in COVID. So we convened the RCS COVID research group in April, met on a Thursday evening, and it was amazing how quickly that took off. Many people joined. It was a virtual meeting, and very rapidly we've got up to 50 research projects, and it's been fantastic in the way that people have worked together, the collaborations, consultants, but also the number of trainees who've been really interested. And very rapidly this has grown into quite a big initiative that's delivered many projects that have helped produce data that's actually improving the way that we manage the patients already.
Can you give us some examples just to illustrate what's going on?
So some of the examples, one of the early ones was an initiative called Operation COVID. This was from a Welsh surgical research initiative. It was led by the trainees, which again is terrific. What they did was they looked at the medical literature in terms of current practice across the world to try and get a consensus on best practice, and looked at some of the issues that people were having in terms of their PPE, the issues of consent, the type of surgery, the vulnerability of patients, and then went out to 300 experts to provide an opinion and a consensus on uniform best practice, and that's been really helpful. Another example, the Birmingham group have produced the COVID surge studies, which have been absolutely phenomenal in terms of the number of patients that they've recruited. And what's been amazing is not just the buy-in from the UK, but actually internationally. And what we've learned very on from that study is we looked at over 1,000 patients, and we looked at the impact of having surgery in the perioperative COVID period, so when they were at risk of COVID. And it was quite shocking. What we were finding is the mortality was about quarter of the patients died during the surgical period within the 30 days of surgery if they had COVID or at risk of COVID. And I think that's been quite helpful in terms of the decision making. We've also learned the patients that greatest risk, if you're male, over 70, with other illnesses, with cancer, undergoing emergency and major surgery, those are the ones that are at highest risk. What else have we learned? Well, that group have also gone on to look at cancer in more detail, and also the impact on the number of operations that are being done. And we've been able to calculate that worldwide there's been over 30 million operations that haven't happened. In the UK, over 500,000 operations that have been postponed, with a current backlog approaching 12 months now at a cost of £2 billion. So, a major social and health economic impact in addition to that on individual patients.
I was going to say a lot of the patrons have been really helpful in helping to finance and get going these research projects. Even they may not be aware of just how huge a role the college plays globally
Yeah.
in surgical research. I mean, I think the college is now the biggest instigator of surgical research in the world.
So, the surgical research really started with the fellows, and then we moved through to the clinical trials. But what's been a really big push is our global surgery initiative. So we've led a number of projects now, and very grateful to the NIHR for funding much of this, with a big global surgeries unit in Birmingham and 5 other research groups, one of which we run in Cambridge on brain injury. There's a burns one in Swansea. And what we're beginning to learn is that the management of patients in the lower middle income countries is very different in terms of these resource limited settings. So we're having to tailor treatments to that resource. But also what we're beginning to learn from these patients is how you can divert resource, how you can improve pathways to improve outcome in these more austere settings.
I'm often asked when I tell people about the college's work in research, um, how can you treat patients like this, like sort of human guinea pigs? And of course, everything that is done directly with patients is done with their consent. But I mean, do you want to explain a bit more of that for those that aren't?
Clearly, the approval and the governance of the way research is conducted is absolutely paramount, and our responsibility is to the absolute safety of patients in research projects. So there's very stringent regulations in terms of the approvals that we need to get for the ethics approvals, the governance through hospitals to check that research is conducted in a really correct manner. What's been very interesting is historically that's actually taken quite a long time, often several months, to get these approvals. But in the era of COVID, when we've needed very rapid action, we've been very grateful to the ethics committees and other governing bodies to actually get these approvals through very quickly. And trials that were often taking months to get going have got going in a very short period of weeks. So that's actually been a really good benefit of research in this era.
And what can you do to capture that, to bottle that, to make sure that we don't slip back into the old ways where these things just used to take months?
So what we've done is we've surveyed the members of the group in terms of the benefits that we've seen, and to try and generate that data in terms of the timelines and to collect that. And hopefully when we start putting forward our non-COVID projects again, we'll be able to maintain this momentum.
Practice has had to change a great deal. How much of that are you going to be able to bottle as well? I mean, what are the good things that have come out of this?
So what's been really good about this is, people think about research, they think about academic endeavor, and it's all very nice when we write some good papers and everybody's quite happy. But what is the point of this? The point of this is that we are generating data to change the way we deliver surgery and to improve outcome for patients. That is absolutely fundamental. And just to give you some examples of that, some of the data out of COVID Surge and some of the other projects are really assisting with the recovery plan. What do we mean by that? How we get back to our elective surgery, and we're learning how to manage the hospital differently with what we call the hot and cold areas, and look at perhaps whole COVID-free hospitals where we can deliver surgery safely. We've looked at how we can change the guidelines. It was really difficult operating during the height of the pandemic. We were dressed in full PPE with the masks and the visors in double gowns. It was very difficult undertaking long operations, looking down the microscope. But we've now got the data that we can safely start to relax some of these restrictions. And currently in Cambridge, we're now testing the patients when they're COVID-free. We are operating under our usual conditions. That makes life an awful lot easier. But beyond that, it's been amazing how we've changed treatment. So for example, the studies of appendicitis, so the HAREM study run out of Glasgow and the Cascade study run out of Southampton, has changed the way we treat appendicitis. Classically, you came with appendicitis, you need an operation. That was the way it was done. But with the concerns over the safety of surgery and access to theatre, we learned that you can safely manage patients, at least in the short term, with observation and antibiotics. So I think that's been really, really interesting. We've also learned that there's certain operations we can do under local anesthesia. So We know the risks of general anaesthesia with the COVID, so maybe we can start doing some local operations. And some of the hand surgeons are to be congratulated. The Reconstructive Surgery Trials Network have shown that you can operate safely on the hand with local anaesthesia. And the orthopedic surgeons, the covert group, have shown that, you know, classically in the recent times, we've done a lot of fixation of fractures. We pin fractures, we put rods in fractures. But again, we're learning that perhaps if we can't operate, we can safely manage these patients non-operatively with traction and casts. So there have been some benefits in terms of refining treatment as well as all the difficulties that we faced.
During the COVID outbreak, we've seen a sort of surge of nationalism and competition. Even within the European Union, actually, countries seem to be competing. We're going to get the vaccines from here. We're going to do this. We're going to outdo you. And it's made the public think that research, scientific medical research, is highly competitive in a bad sense. Actually, has that happened at all, or is it really just as collaborative as ever?
So what I've impressed me most is this collaboration and the way that people have gelled together. And the COVID research group, when we have our webinars, somebody will present it and then somebody will say, well, I was thinking about that. And they'd have gone off down two separate routes and now they're talking to each other and working together. So it's been really impressive how people have formed new collaborations that didn't exist before. That's not to say we don't want competition, because competition is quite healthy. And the Leeds MedTech Cooperative set up what they called their COVID challenge, where they put out an advert for people to come up with really novel ideas of how to beat COVID. That led to 68 projects that came through to them, all sorts of different things, new decontamination sprays, looking at drugs that you could give as preventatively to healthcare workers to stop them getting COVID, looking at new technologies in theatre. You know, we do this checklist before surgery, like a pilot does before a flight, where you go through very carefully all the steps. That's quite difficult to communicate in the full PPE. So we've looked at way we can do that through apps, and all these ideas, these 68 ideas have come together, and then we're looking how we can take some of these forward. So it is in some ways it's quite an exciting time.
It's exciting. It's expensive doing research. Some of the patrons have contributed hugely to it. How is this being financed? How is this going at the moment? Because these have been very lean times.
It has been very difficult, and it is lean times. I think we have been very grateful to certain funding sources, and the patrons, as always, and the college have been very helpful, and we have been able to pump prime a number of projects through college resources, which is good. Of course, we'd like to do more. The NIHR, so the National Institute of Health Research, have again been very helpful in effect ring-fencing money for COVID research, and again some of that money is now filtering through to the surgical studies.
You mentioned this sort of big overlap that there is between surgery and, well, in a sense, virology. I mean, certainly infection control. Is there actually research going on with virologists as such?
Yes, so we are working with many health professionals and non-health professionals who we didn't historically work with. So we're working with virology, we're working with public health specialists. You know, we're learning. You know, there's quite a detailed study on how the virus actually sits within the peritoneal cavity, within the abdomen, taking different swabs, collaborating with basic scientists. The aerosol science is something else that we've got really interested in. There is the British Aerosol Society. You know, this is their moment. These are the people who are now, you know, who'd have thought that would be relevant? You're thinking about deodorants in aerosols, but actually suddenly the British Aerosol Society has become so crucial. We're learning how the disease is spreading droplets, how it's transmitted. And, you know, that impacts on the operating theatre to quite a large degree. I mean, I personally have learned so much about operating theatre design and how air flows through operating theatres. You know, in orthopedic theatres, we use what's called laminar airflow because it's the way the air moves across the theatre and the patient to reduce infection. But we need to be conscious that the airflow isn't actually propagating viral transmission.
So this is going to have an effect, you think, very long term including the design of theatres?
I think we are learning about the design of theatres. We're learning about the volume and rate of airflow changes. You know, this is going to be with us forever. And you know, I think as difficult as it's been, I think that there are going to be benefits in terms of improving what we do.
How are we going to catch up with those? In the UK, you said 500,000 patients have had their operations postponed. I can't remember what the figure was globally. It's horrendous. How are we going
Globally,
to catch up? Sorry, what was it globally again?
globally, we're looking at around 30 million, and that was the previous data. So it will have gone beyond that.
Yeah. How are we going to catch up?
So we need to look very carefully at the patient pathways, whether we can do things differently, and collaborative working across a number of specialists, and really trying to protect particularly elective surgical operating. And I think through this cold area, hot area is one way we can do that. But I think it's just important that we emphasize these numbers. One of the big worries that we've always had with COVID is that everybody's been focusing on patients with COVID, but we must continue to emphasize the tragedies that happen to many patients who did not have COVID, patients who've got cancer and other pathologies whose treatments have been delayed. But a particular concern, and I think these are the patients that are going to be potentially suffering most, of those who need the elective surgery, perhaps for pain. So some of the orthopedic surgery, the joint replacement. So we need to take them out separately and really package that, looking at different hospitals, different providers where we can maintain that activity, you know, even if the second wave hits us quite hard.
It wasn't that long ago that research was sort of a bolt-on for the college. I mean, it was something that was good to do, but it wasn't a core. It is absolutely core, wasn't it? I mean, it's really become a sort of hugely mainstream part of college activity.
It's become really important in the college, and that's terrific. And I think you know, the credit goes to everybody in the college for raising the profile of research, but particularly the next generation of surgeons. So we see it from medical students through the trainees who are really wanting to engage in research, coming up with all these exciting projects. And you know, the surgical trainees now, they're all getting engaged in it. The trainee collaboratives where they all work together, particularly in terms of the trials, has been absolutely amazing. It's been fantastic what they've achieved. I think there's also a recognition that research is good for patients, not only in terms of findings to help in the future, but we know that patients who are in research studies get very well looked after. You know, even if you're in the placebo arm of a surgical trial, you get very close attention. So I think, as well as learning more for future practice, being in a study, I think it helps the individual too. Yeah, it is exciting times.
Well, good luck for the future of these exciting times. Hutch, thank you very much indeed.
Thank you very much. Thank you.